Buenos días. Me gustaría mucho de agradecer a toda la organización de invitarme, pero las últimas palabras que hablo en español, transmito in English. So we came today to talk about the role of the MRI in active surveillance. I am a radiologist. Since 1990, the practice of the urologist is changing. The benefit of the radical treatment by surgery or radiotherapy is not clear for these patients. New alternative treatment option like focal therapy is arrived, and active surveillance before a radical treatment don't affect the carcinogenic prognosis. The challenge now is to identify the aggressivity of the tumor at the moment of the diagnosis. To predict the individual risk of progression, the classical parameters are insufficient. Now, the clinic, biology, or histology. MRI can better characterize tumors and coupled with molecular biology, both can predict the risk of each lesion and then help in the choice of the treatment. Practice is now changing with this evolution. The criteria for inclusion is worldwide new now. Histologic proven adenocarcinoma of prostate. Men should be fit for curative treatment. Clinical stage T1 or T2. Gleason score not more than 6. 1 or 2 biopsy cores invaded with prostate cancer. PSA less than 0.2. PSA less than 10. And participants must be willing to attend the follow-up visits. Adequate biopsy sampling. So in 2010, CLOTS study 452 men showed the 10-year survival rate of low-risk prostate cancer on active surveillance is 97%. And in 2012, a randomized study in PSA era showed radical prostatectomy didn't decrease the death rate compared to observation over a median 10 years follow-up period in men with low-risk prostate cancer. So you can see these two studies here can show that active surveillance approach is very good for low-risk prostate cancer. So usually, you observe or you monitor these patients with a PSA every 3 or 4 months for 2 years, then every 6 months. We repeat biopsies starting at 12 months post-diagnosis, then every 2 or 3 years thereafter. Digital rectal examination yearly, and MRI now is being evaluated and incorporating protocols. The role of the MRI, and nowadays we can detect significant tumors with high sensitivity and specificity values. The multiparametric MRI 3T can detect, can localize here, can measure the volume of the tumor, can measure the aggressivity of the tumor with other sequences, and can eliminate an aggressive lesion. Doesn't matter. I would just to show here an image, because after the sequences obtained, we can fusion the anatomical T2 sequences with the metabolical value of the restriction value of the restriction diffusion. And then we can obtain it, an image that can better use for the radiologist and for the urologist. But this fusion is only possible if we have exactly the same thickness, the same slices of the images. And this is important. We work in Geneva with a multidisciplinary approach. This is very important. We put the patient in the center of our worries, and we try to answer the question of the patient. This is an example how we send the images to the urologist. So we do a kind of resume of the problem. Here you can see in the T2 anatomical sequence, a big tumor, anterior tumor, in the sagittal view, and with this anterior tumor is with detection within the after contrast. And then in our meetings, we compare the results of the MRI with the results of the biopsy. And you use the same sectorization. The pathologist and the radiologist is really approach. And you use the same sectorization. And it's not only important to detect tumors, but we have also to know how to communicate with the urologist. The performance of the MRI is nowadays, we know that is better. The negative predictive value is about 26% if we use TREATME and an expert radiologist. So it's really important how we can do this MRI. And do you see the under detection of significant tumor of 4%? The goal is to detect the significant tumors. The guidelines of AAU 14 is the criteria for very low risk patients to include patients in active surveillance is low PSA, less than 2 positive biopsy score, and less for 5 millimeters involvement of any biopsy core. No Gleason grade 4 and 5. You don't see any MRI in these guidelines. But the guidelines of British NICE in 14 say, offer active surveillance as an option to men with low risk localized prostate cancer for whom radical prostatectomy or radical radiotherapy is suitable. And they include now MRI as enrollment in active surveillance, if not prevalence before. They monitor patients with PSA kinetics each 3 months. At 12 months, they do biopsy. So if there is clinical or PSA change during the monitored active surveillance, they do a MRI or rebiopsy patients, and then they reclassify patients with the stratification risk, low risk, intermediate risk, or high risk. This meta-analysis, I think, is really interesting to discuss here today, because it is a recent meta-analysis that take a lot of published studies, and we are trying together to answer these 2 questions. Can MRI detect significant disease in men on active surveillance? Can MRI be used in place of repeat standard biopsy to detect progression over time? So you help me. Here, this meta-analysis, they share the studies. 10 studies compare prostatectomy, the gold standard, with MRI in active surveillance. 7 studies compare the biopsy with the MRI in 7 studies. And 2 studies repeat MRI on active surveillance. This diapositive show upgrading of radical prostatectomy of active surveillance men with preoperative MRI. Do you see here, there is many difference in the number of the population, many difference here in the methodology, and we can see only one thing very interesting in this study, recent study. They show a big population for 6,400 patients, and the results in the correlation with the upgrading and the MRI is correspondent. So, in resume, the predictive value positive of MRI in this data analysis was 73%. From the 73%, upgrading occurred in 43%. And in this data device, MRI was negative in 23%. And from this 23%, upgrading occurred in 27%. So we have to be really prudent to analyze these results. We can just to see there is a better, we can see the MRI can detect significant tumor in 43%. But there is many limitation with this data analysis. You can see small number of studies, lack of standardization within studies, small selective patients, and depend on initial selection criteria of patient. Our preliminary results of our study, we compared the detection of the MRI, the lesion MRI, and with the perineal biopsies. I know it's a small series, and it's a preliminary results, but you can see that we have a very good concordance between the MRI and the biopsies in 95%. And the most important, that we confirmed 15 anterior high-risk cancer suspected on MRI, and 2 intermediate risk. The meta-analysis also studied the accuracy of MRI in reclassification for men on active surveillance. It's the same problem. Do you see here is a small population in the 4 studies, and the way how they repeat the biopsy is really different. In this study, they do cognitive ultrasound biopsy. In this study, they do with MRI guided, direct. And in both these 2 studies, they do MRI ultrasound fusion in the different techniques you're using. And we see here, there is many variable results. In resume, different methods to achieve biopsy in several studies don't permit to be conclusive. A small series and a small number of studies is a problem. No standardization in the technique of performing MRI and no standardization in the interpretation is also a problem. But we hope that in 2016, now, with several technical improvements of multiparametric MRI and a standardization of the radiologist interpretation with the arrival of PIRADS classification, could be changing, and the most important, we have to be really close to the clinicians and work in a multidisciplinary team. And to be a better radiologist is really important to do always a correlation with our results with the histology in the meeting and a tumor burden in order also to select better our patients. In practice, these patients have 60 years. He is initially a high PSA, a normal rectal examination. First biopsy, we found a Gleason 6. They have a tumor volume at 10%. He is admitted on the program of surveillance active. We included MRI first evaluation and annually. Donc, do you see here the image that I would like to show you in the first of the presentation? That we can see here the T2, the anatomical way. So here is the first examination of MRI with a restriction of the ADC. And we put this information in the T2 anatomical sequence. This is the first MRI. We do. The T2, do you see? I can't see very well where is the tumor, where is the limitation of the tumor. I know that is in the posterior region of the prostate, but I don't see the limitation. And here is the MRI 1 year after. And I can't see if there is a progression or not, only with the sequence. That's why it's really important to do this fusion of images. And here is the first examination that I show you with the restriction. And here is the evolution of the high B value. The diffusion is really important because we can see the hypercellularity of this tumor. And I conclude with both three parameters that in this patient there is a progression of the tumor. And after this patient goes through the prostatectomy, because there is also other parameters that is changing, and in the prostatectomy is confirmed the progression of the tumor. So, take-home message. MRI is positive in this meta-analysis in 2/3 of men suitable for active surveillance. Yes, MRI can be used to detect significant tumors. But no, at present, there is no robust published data to support the use of MRI in place of repeat standard biopsy to detect progression over time. MRI, I think, is really interesting in monitoring men on active surveillance. Gracias for your attention.
Thank you very much, Dr. Martins.